Okay, so we're going to talk about infantile spasms today. Here are my disclosures, of which there are many. All of these companies are interested in infantile spasms to the extent that they already have and market therapies for infantile spasms or are developing promising new therapies for infantile spasms. So as we encounter potential conflicts of interest, I will let you know about those. And we should just start with a video of infantile spasms, but I bet everyone that is going to watch this video is going to recognize these. And what we're seeing is a cluster of arm movements, shoulder shrug, and especially eye movements with each episode. Now, this is one of the better videos of infantile spasms from YouTube. So just a little bit of terminology. It can be very confusing, but infantile spasms and epileptic spasms basically mean the same thing. This term can be used to describe the seizures themselves, or it can be used to describe the epilepsy syndrome, meaning the combination of the seizures, the EEG changes, and impact on development. Classically, the term West syndrome refers to the seizures, the EEG pattern, namely hypsarrhythmia, and developmental delays or developmental stagnation associated with this disorder. Here's an example of hypsarrhythmia and normal EEG. It's a pretty big difference, but I may be making it a little too easy to tell the difference. There are many cases where the patient's brainwaves are somewhere in between, and it's a lot harder to say that it's definitively hypsarrhythmia or that it's definitively a problem. When we think about development of patients with infantile spasms at the onset of disease, about half are normal at that point, but about half already have developmental delays that are likely occurring either because something is happening before we see spasms, before we see the seizures, that there could be brainwave problems that are hurting development at that point, or that the underlying cause of infantile spasms is itself something that is potentially devastating and that affects development, and that can begin, essentially at birth or before birth. When it comes to finding the cause of infantile spasms, we are getting better, but I would say we're not good. So in about 2/3 of cases, as much as 80% in some series, we identify the underlying cause of infantile spasms, but still in about 20% to 33%, we're still unable to figure it out, despite our best neuroimaging, despite our best genetic tests. So it still remains a big, significant challenge. And when we think about those categories, we often say that patients have structural disease, meaning that there's something we can see in their brain that is abnormal, like like something like a tumor or something like cortical dysplasia, where there is physically abnormal brain. There are a variety of genetic disorders. There are metabolic disorders. So these include disorders in which our bodies have trouble processing and breaking down fats, carbohydrates, or proteins. And these can lead to infantile spasms and many other disorders. And again, there's a large chunk of patients with unknown cause. And there's also some overlap here. So some disorders are genetic in origin and also cause structural abnormalities in the brain. And the big number one example of that is tuberous sclerosis. There are also essentially all disorders that we call metabolic are also genetic, meaning they are not necessarily inherited, but they are caused by changes in our DNA, the sequence of genes, and that those can result in problems in our body's ability to break down, again, fats, proteins, and carbohydrates. So this is a look at specific causes of infantile spasms at UCLA, and you can see that there is a big chunk of patients with unknown cause, but other big causes include things like focal cortical dysplasia, tuberous sclerosis, HIE or hypoxic ischemic encephalopathy, and then a whole bunch of other mostly genetic causes of infantile spasms. Now, we should probably talk about genetic testing, and this is something that is kind of rapidly evolving and that is really enriching our ability to figure out why kids are having infantile spasms at all. And there are lots of different types of genetic testing, and I think it can be very confusing, and the vocabulary is not easy. But in general, the first easy test we do is something called a chromosomal microarray. So that's here at the left. And the y-axis here is kind of the yield of these testing strategies. And you can see that chromosomal microarrays are easy, but they don't get you very many answers. These really only explain the cause of infantile spasms in about 5 or 10% of patients. And this is a test that looks really at the structure of the chromosome, looking for extra chromosomes, missing chromosomes, or extra pieces of DNA or missing pieces of DNA. These tend to be these tend to identify the cause of infantile spasms in cases in which there are structural abnormalities either in the brain or elsewhere in the body. So, for example, facial features, short or long limbs, short or long fingers. Those sorts of abnormalities are often associated with genetic diseases that are chromosomal in nature. What we have next is a gene panel, and this has become increasingly popular because of a pharmaceutically funded effort to provide free genetic epilepsy panel screening for all patients with seizures under about the age of 8. And because it's free, it's much easier to get authorized by insurance. You essentially don't need any insurance approval. And what these tests do is sequence about 50 to 300 genes that are linked to epilepsy. And that gives you a yield of about 20%. So in about 20% of cases where we suspect a genetic cause of infantile spasms, we can identify it just with that quick gene panel. The next step up is a big step up. Whereas the gene panel is looking at about, again, 50 to 300 genes, exome sequencing sequences all genes in the patient and both parents, and that amounts to about 22,000 genes in each person. And the idea here is to look for gene changes or sequence changes in our DNA that are present in the patient, but not present in the parents. So especially non-inherited disorders. And that's where this big yield comes. So it's about twice the yield of a gene panel, but much more time consuming, much more expensive. So whereas the gene panel is essentially free for patients in the United States, exome sequencing is more like several thousand to 10,000 per patient. And kind of the next hope is genome sequencing, where we not only do we sequence all 22,000 genes, but we sequence all of our DNA. The issue so far is that yield seems to be pretty modest, that sequencing the entire genome leads to very few additional diagnoses. But there are a few reports in small groups of patients suggesting that there may be at least a modest improvement in diagnostic yield. So how do kids with infantile spasms end up? Unfortunately, we're not doing that good. So whereas 20% of patients are cured, and these tend to be patients with mild or unknown causes of infantile spasms who are picked up quickly, meaning we get the diagnosis quickly, we start treatment immediately, they respond immediately. Those are the kids who are positioned to respond really well and have good long-term outcomes. Unfortunately, about 15% of patients die by age 2. And this isn't really because of the seizures. This is probably because of immune system compromise. And when your brain is not functioning well, lots of other body systems are not doing well, especially the gastrointestinal tract. So kids with long duration of infantile spasms often have trouble swallowing. They can't swallow their saliva well. And when you don't swallow saliva well, it has a propensity to enter your lungs. And unfortunately, our saliva is very dirty, lots of bacteria, and our lungs are supposed to be very clean. So when saliva goes into the lungs, it carries a tremendous risk of pneumonia and infection, and that is potentially lethal. And that is the #1 killer of kids with infantile spasms. Now, unfortunately, we've got this big group in red, and these are the patients who often don't respond quickly to treatments for infantile spasms or don't respond at all. And they unfortunately suffer high rates of lifelong epilepsy, especially transition to a disorder called Lennox-Gastaut syndrome, as well as poor development and high rates of autism. So the risk of autism in infantile spasms is in the neighborhood of 30 to 40%. And again, those are in the patients who tend not to respond to therapy quickly. So these are the big targets for research in infantile spasms. We're trying to change these outcomes and change them drastically. So this is an illustration of IQ. And what I'm trying to highlight is the urgency of diagnosis and treatment. So IQ is basically a test score that shows something like what we might call intelligence or development. And average is 100, and each standard deviation is 15 points. So normal is anywhere from 70 to 130 is what we say in general. And the issue here is that compared to kids who get an immediate diagnosis and treatment, those who have a delay of just of about a week, 8 to 14 days, they on average lose 4 points of IQ. And if you delay another 2 weeks, you lose another 4 points. If you delay another month, you lose another 4 points. If you delay anything after that, you lose another 4 points. So just because of delayed identification of infantile spasms and delayed treatment, we're getting a pretty substantial reduction in long-term intelligence. And one goal that we have is just to simply identify spasms quickly, treat them quicker, and just by even using the existing tools and medications at our disposal, we can dramatically improve a lot of developmental outcomes. Because there are a lot of kids who will respond to therapies we have, but because we begin those therapies too late, there's a substantial reduction in their long-term development. This is data from UCLA, and we're not doing that good. So when we looked at 100 consecutive patients with infantile spasms, we saw that diagnosis and treatment was prompt in about a third, under 7 days, but it was poor, meaning 2 to 8 weeks in about a third of patients, and what we might call abysmal, meaning taking more than 2 months to figure out that the seizures are infantile spasms and that they need to be treated with therapies that actually work for infantile spasms. So this group that is abysmal, we would calculate that they are losing a full standard deviation of IQ just because of the delay in diagnosis and treatment. And why are these delays happening? Unfortunately, the issue is just physician and provider knowledge of infantile spasms. There's a big gap where the general population doesn't know about infantile spasms. Pediatricians don't adequately know and remember what infantile spasms are. Emergency room providers don't know what infantile spasms are. And a lot of the burden in figuring this out is actually placed on parents who need to do their own diagnostic search online to figure out what's going on with their kid. And that is a huge, huge problem. And the usual barriers to care, the usual barriers to quality healthcare are not present here. So in our analysis, we didn't see that there was no effect on your type of insurance. So having good insurance didn't get you quicker diagnosis and treatment. Socioeconomic status didn't work. Being rich was no better for you. Whereas in most other diseases, having wealth and having access to quality healthcare is usually a big predictor of health outcomes. Not true in infantile spasms. And again, there were no disparities based on race or ethnicity, rural, living long ways from big cities and big academic medical centers did not affect outcomes. So it's all about, at this point, the biggest problem, the single biggest problem is that nobody knows anything about infantile spasms until they've got it. So when it comes to treatment, the three main things are hormonal therapy, and in principle, ACTH, a second drug called vigabatrin, and surgery for very select candidates. And the effectiveness of these therapies varies a bit, but none of them are nearly as good as we would like. So ACTH and hormonal therapy in general is about 55% effective, vigabatrin about 36%. Surgery in good candidates can be as much as 70% effective. And by effectiveness, I mean disappearance of infantile spasms and normalization of the EEG. So disappearance of hypsarrhythmia and disappearance of similar patterns. But we've got some big side effects with all of these therapies. So immune suppression is a big problem with ACTH and is a potential cause of death. We've got vision loss with vigabatrin, which is incredibly scary, but I think we're actually, we're probably falsely scaring parents with this potential side effect. And surgery obviously has its complications. There are, risk of surgical complications, and you're removing brain. So you would expect that by removing brain, you're going to impact some function long-term. And in general, who is a good surgical candidate? There are other lectures today dealing with this, but briefly, I'll just say that when the EEG identifies a particular part of the brain that is dysfunctional, when an MRI shows a structural abnormality in that same place, and when a PET scan shows an area of brain that's not using glucose, not using sugar in the same way compared to the rest of the brain, when those three things match up, those are the patients who tend to be good surgical candidates. Now, there's a lot of nuance to this and lots of exceptions to this rule, and many patients who do well after surgery who don't have a compatible result with all three of these. Often it's only two, sometimes it's only one. And that is a big ongoing challenge with regard to the surgical management of epilepsy in general, trying to figure out who are the best candidates. This is an example of a patient with hemimegalencephaly who had a very obvious structural abnormality that I won't go into, but also had an abnormal PET scan. And when we fused those two images, it became very clear that this was the area that was dysfunctional. And this patient underwent a hemispherectomy and did well long-term. This is a picture of EEG done in the operating room. This is kind of the last final stop when you're deciding what brain needs to be removed and what brain is kept. This is the test we use to refine those boundaries. This is before and after for that patient. So here we're seeing a big area of the brain that was removed and the rest of the brain was disconnected. And this patient became seizure-free. There are also big costs with all these therapies. You can see in the column at the right that none of these are cheap, and that, aside from the devastating developmental impact of infantile spasms, there's a huge impact on the economy. Now, a big contemporary debate is centered around ACTH and prednisolone. So these are two hormonal therapies, and they have some big differences. Now, is the response rate different? This is debated, and there are quite a few modern data suggesting that the difference is small and perhaps non-existent. Side effects are high for both of these. Cost is very different. So ACTH costs about $120,000 to $160,000 per patient these days. Prednisolone is about $100 per patient, and it's so low that you can't even see it on this graph. And what is maybe mind-boggling is that the cost of infantile spasms really dwarfs the cost of ACTH, whereas we've got millions here. We would estimate that the cost of treating a patient with infantile spasms when they fail initial therapy is about $7 million per lifetime per patient, whereas the cost of ACTH is a tiny fraction of that. So if we had a therapy that was really effective, that could improve long-term developmental outcomes, we would be willing to pay a lot of money as a society for that drug, because we were spending incredible amounts of money on the care of children with infantile spasms and the sequelae of infantile spasms. So transitioning to vigabatrin, the one big thing to remember is that it's much more effective in patients with tuberous sclerosis, but still decently effective in patients without tuberous sclerosis. This is an artist's rendition of the feared peripheral vision loss that can occur with vigabatrin, but this seems to be a much bigger issue for older children and adults, and seems to be mostly a non-issue for infants who are treated with vigabatrin. And I think my big message to people is that you shouldn't be afraid of a low risk of permanent vision loss from vigabatrin. You should really be afraid of poor developmental outcomes, including poor cortical vision, meaning the brain's ability to interpret the information that the eyes send to it. That is very much vulnerable when you have uncontrolled infantile spasms. So really, the side effects of vigabatrin are nothing compared to the effects of infantile spasms. So again, this risk seems to be much higher in adults. It seems to be linked to high doses or long durations of vigabatrin. The risk is much lower in infants, lower with lower doses. There are other side effects of vigabatrin, and these include what are called vigabatrin MRI toxicity. So these are two MRIs. This is the same patient, upon starting vigabatrin, and we can see that this area of the brain called the thalamus turned very bright white, as indicated by the red arrows, and then after withdrawal of vigabatrin, it normalized. Usually this is asymptomatic. It occurs in about 20% of patients who get vigabatrin for treatment of infantile spasms. It does not affect adults who use the drug, so it's kind of the opposite phenomena or opposite pattern that we see with the vision loss. There are rare cases where this causes symptoms. So there are cases where kids can be profoundly tired or fatigued when they get this side effect, or that they can have movement disorders. And there are now rare cases reported where it's affected heart rate or breathing. But again, those are pretty rare. Those are in single-digit percentages for patients with infantile spasms. And again, don't be afraid of vigabatrin toxicity. Be afraid of infantile spasms and not being able to control them as quickly as possible. Yeah, and this is really just showing that same thought. So when you think about vigabatrin, there's a very small risk of vision loss. There is a sizable risk of MRI side effects that are usually asymptomatic. But think about the burden of not responding to therapy. This is a much, much bigger risk. So taking vigabatrin is much lower risk than not taking it for most patients. And in general, when we compare the hormonal therapies, meaning ACTH or prednisolone, they seem to be much more effective than vigabatrin. Big question is, well, what if you combine the two? And it appears from a recent study that the combination is much more effective short term than hormonal therapy by itself. And for this reason, a lot of people have adopted combination therapy. This is kind of the difference from that study. So it was about 72% response for patients who were getting combination therapy, meaning prednisolone or ACTH with vigabatrin versus prednisolone or ACTH alone. So there are some differences though, and we often pay a lot of attention to cost. So certainly doing that combination is much more expensive. There's much more risk of MRI phenomena, but you're getting higher response rates. One tricky thing though is that when patients respond to combination therapy, you don't know what therapy has worked. And that can introduce some confusion later when you are withdrawing therapies. You don't know which one to withdraw first. You don't know how much the vigabatrin was helping. And there's a lot of uncertainty about how long you should continue vigabatrin after response for infantile spasms. This is a snapshot of the current UCLA protocol. And in brief, we get new patients with a new diagnosis. We give combination therapy with prednisolone and vigabatrin. We give that for 2 weeks. If they're responders, we say great. We stop the prednisolone and we continue vigabatrin for a year. If they haven't responded, we start ACTH. So we substitute ACTH for prednisolone, continue the vigabatrin. Do that for 2 weeks. If it doesn't work, we start second-line therapies, and there are a long list of those, and we'll talk about those in a little bit. And when ACTH does work, we stop it and then continue vigabatrin again for a year. But I would emphasize that there isn't a lot of consistency across practitioners or across centers. So a lot of variability in how long we treat with vigabatrin. And that's because of differing opinions and impressions of the risk of long-term vigabatrin therapy. In my own opinion, I think it's pretty safe. And to the extent that it may prevent a relapse, I am much more afraid of an infantile spasms relapse than I am afraid of long-term effects of vigabatrin. So there are lots of second-line therapies, and we'll talk about these a bit. And no modern discussion of infantile spasms is complete without a discussion of cannabidiol. And a lot of people watching this have already heard of Charlotte's Web. And when we think about cannabinoids, we kind of group them in 3 groups. So there are what we might call artisanal cannabis extracts, and these are things like Charlotte's Web or CBD oils. And these are whole plant extracts from plants that are bred to have a lot of CBD, a lot of cannabidiol, and relatively low amounts of THC, which is the psychoactive ingredient of marijuana or of medical marijuana. There is pure cannabidiol, which is a pharmaceutically produced chemical, but it's also plant derived. So it starts with similar plants that are used to make these extracts, but those extracts are further purified to essentially have pure cannabidiol. And then there are products like synthetic cannabidiol. So these are products that were never in a plant, they were made solely in a laboratory. But again, it's the same chemical, and there are actually numerous companies who are trying to develop these for epilepsy and other indications. So when you look online, the impression is that cannabidiol products work for everything under the sun, that they work for everybody, that they're safe, there's no side effects, and only rarely will you see an online report suggesting that cannabidiol or CBD doesn't work. Whereas if you were a fly on the wall in our clinics, you would probably get the opposite impression, that there are a lot of people who have tried these products, the vast majority saying they didn't work, but that a few saying, well, actually, it did work. And a big challenge we've had is trying to reconcile these 2 sources of data. Who's right? What are the biases that are feeding into this? And the way we approached this was by doing first a survey of parents who were administering these products online. And what we saw was very similar to those online reports, which is not a big surprise, in that it was working across the board for many different kinds of epilepsy, including infantile spasms with Lennox-Gastaut syndrome, as well as Dravet syndrome, and all other forms of epilepsy in that survey. And then it included many patients in green here who became seizure-free, and relatively few patients who were any worse when they took the drug. So this was inspiration to chase this lead and to really inspire the pharmaceutical development of cannabidiol. Now, specific to infantile spasms, the experience has not been as clear. So whereas these drugs were very effective in the treatment of Dravet syndrome and Lennox-Gastaut syndrome and are supported by multiple multi-center clinical trials, and it's now approved by the FDA, we are not there for infantile spasms. And a lot of that is because the early studies have not been clear. So here's an example of a study that we did at UCLA in which we treated 9 patients with infantile spasms, and we had 1 patient respond. So 1 out of 9, that was an 11% response rate, which was not great. It was better than we would expect from natural history. So meaning the likelihood of having resolution of infantile spasms and resolution of hypsarrhythmia in a 2-week period is about 1%. And to the extent that we saw one responder, 11% of those 9 patients, that was better, but maybe not statistically better. This is what that single patient looked like, though. That single patient was having about 100 infantile spasms per day, had a very abnormal EEG, and that after a single dose, the parent reported that the patient was seizure-free for several days, did have a single cluster of spasms on about the 5th day of treatment, and then stayed, again, seizure-free for the duration of the 14-day study. This is the EEG of that patient on day 14, and hopefully you can see that there's a difference here to the trained electroencephalographer. This is a big difference. And it's hard to imagine that the EEG improved in a way that you might attribute to placebo or something like that. But again, this is not convincing enough to merit FDA approval, certainly, but convincing enough to inspire further study. So there was a clinical trial planned with 180 patients to look at vigabatrin and a placebo compared to vigabatrin combined with cannabidiol. And this study was all set to go and began recruiting, but the manufacturer went out of business. And this is on hold. We're hoping that this can be salvaged and restarted with a different manufacturer. So some key points to remember. First, prednisolone and ACTH are the most effective therapies for infantile spasms. Combination therapy seems to be superior short-term, and we just don't know whether long-term outcomes are better with that approach. Surgery is an excellent option, however, only among select candidates who have identified focal disease, meaning patients where we can remove a piece of visibly abnormal brain. Those are the patients who have great long-term outcomes after surgery. All other therapies, unfortunately, have pretty limited effectiveness, and we are desperately searching for new drugs. And among those, cannabidiol development is promising, but there are quite a few other drugs in the pipeline that have some potential. And if there's one idea that I want to leave you with, it's that we shouldn't be afraid of the side effects and cost of any of these therapies. The thing to be afraid of is enduring infantile spasms and relapse of infantile spasms. That's where we need to focus our energy and stay focused on the real goal. The real goal is always getting rid of these seizures. Okay, well, thank you very much. Happy to entertain any questions for the robust live audience here. Okay, well, if there are no questions, I will leave you and have a wonderful day. Take care, everybody.